Wonderful. Well, as promised, welcome everybody, wherever in the world you might happen to be today for this, the third webinar in this series with the KDIGO Genetics and CKD webinar series. I'm so proud to be able to chair today. My name's Andrew Mallett. I'm based here in Eastern Australia, where we're currently tolerating the monsoon season. In this module, number three, which is a CME accredited module, as I'll walk through in a moment, we'll be exploring understanding genetic test results and particularly using case-based illustrations. At the beginning today, I'd like to highlight that obviously the support for this webinar series, this particular webinar is supported by an educational grant from Natera to KDIGO. As I mentioned, my name's Andrew Mallett. I'm an adult nephrologist, amongst other things. I'm based here in Townsville, in the tropics, in Northern Australia, where it's about 5 in the morning. And I hope that wherever you are is warm and comfortable and safe at this time. Some brief information about the CME program information here for understanding genetic testing's case-based illustrations. There's the opportunity to potentially earn 1.0 CME credit for attending this CME webinar. Please refer to the link in the Zoom chat that we'll be putting up in a moment to review that CME information. And at the end of the webinar, the CME evaluation link will be shared with a QR code for those who'd like to claim that credit. This activity is jointly provided by the Global Education Group and KDIGO. It's my absolute pleasure today to be joined by three outstanding, truly outstanding faculty from across the world to help in delivering this webinar. First is Professor Oliver Gross from University Medical Center Göttingen in Germany, who needs little introduction and is an absolute expert in so many areas in this space, but especially in collagenopathies and Alport syndrome. Next is my friend and colleague Matt Lanktree from Canada, McMaster University, who has a specific interest in cystic kidney disease, amongst other things, and we'll be presenting a little bit about around some specific cystic kidney disease cases, and as an adult nephrologist. And last but absolutely not least, the person who'll be taking us out today at the beginning is Albertien van Eerde from University Medical Center Utrecht in the Netherlands, who is an amazing clinical geneticist with a special skill set and interest in nephrogenetics, and with whom I have immense joy in communicating with frequently about different things as we see how this space is unfolding at an international level. Albertine, I'll hand over to you.
Thank you very much, Matt. Is everything clearly visible from your point? Great.
Perfect.
So, oops, now I do need to select the PowerPoint in order to switch. Yeah, I have no disclosures. First of all, I want to warn you that my slides sometimes are pretty full, and I want to invite you not to try to read all small print, but to maybe in the future go back and read back, because that's what it's meant for, to be maybe a little archive to refresh your memories. This picture I was allowed to bring from the European Society of Human Genetics almost 2 years ago, and it's here to illustrate for you that the genetics process, it's not simply you request a test and get a result back, but it's quite an extensive process. And in all the steps of the way, things can go wrong. And this makes that for all aspects, you need highly trained professionals. And it's important to not overestimate what you can, or and not underestimate what you can't do. The picture right on the right downside, you've seen in the webinar from Hila, and maybe also seen in the KDIGO paper from 2022, where there's ideas about implementation, and that you don't need many experts, but you need kind of a gradient. So a few super experts, and then some more medium experts, and then the general nephrology practice. As a Definitely as a personal statement, I want to put out here that general nephrologists don't all need to be nephrogeneticists, but I think the goal should be that every nephrologist, one, recognizes who is eligible for genetic testing, and two, can offer a broad kidney gene panel in CKD to a symptomatic index patient who was not tested before and where affected family members were not tested before. Therefore, it's important to know your local, your regional, your national infrastructure. Where are the experts? And also, for instance, in terms of payment. If you request a test and then the insurance will not allow another test for another 3 years, you need to be more critical than if that's not the case, for instance. And you also need to know how the testing system works in order to establish an agreed situation where you know when to be in touch with the nephrogeneticist. So this is what that might look like. And you can devise a similar scheme with your nephrogenetics hub. This is an example from Australia where it's kind of a stoplight principle where in green are the cases where general nephrologists can offer a test themselves. That's why I may put a DIY there. In orange or in amber, the cases where a discussion with a multidisciplinary team is in place. And in red are the cases where it's specified to definitely not test in general practice. You see that even I already adjusted it a bit to how it would look like in our situation. For instance, if you're not sure what to test to request, please give us a call. If there's extrarenal features or need for a rapid diagnosis, be in touch. These kind of things are important. And this is definitely a living document. It's something that you should have to evaluate every once in a while. Also, maybe because your own skills are improving. But definitely do it in conjunction with the multidisciplinary team. So you've seen these lists. Hila and Ali have shown them to you about which patients are eligible to offer genetic testing. But I did want to add two things in yellow. First of all, sometimes we don't realize that being in a reproductive age and patients who would actually have concerns about passing on the kidney disease to their offspring might be a reason in itself to offer genetic testing, even if maybe you think the a priori chance is not that high. It might be very relevant for SIBs or relatives, while less so for the patient. So even if for your own patient you don't need it, it might be worthwhile for the relatives. And also, this is something that's not often mentioned, but when it's a bad moment, other things are more important. Please store DNA because then the testing can be done later. And basically, we need to shift from justified testing to justified non-testing, I would say. This is a hell of a slide, but basically, pre-test counseling is like shared decision-making. So you discuss the pros and cons. You have to know what kind of genes are on the panel. You have to be aware of the needs in terms of family planning and a larger family. And what's especially important is that when you're aware of maybe doing a genetic test, timing can be your instrument. So then you can discuss with the patient, okay, well, maybe not now, but then maybe in a few years, or but not forget it. And this is important. When the patient does not want to test right now, we don't drop monogenic from the differential. And you have to make sure that you follow the agreed procedure, which is often a written informed consent form. One of the things that are always said is that the insurance consequences are important, but when you stick to testing symptomatic index cases, and especially in patients with considerable CKD, having the CKD in itself will already have insurance consequences. So then it's less big of a deal than when you're testing healthy patients. So then when you get the result, probably many of you have seen one and have seen that there's a class system, class 1 to 5. And that's actually according to the ACMG guideline, which is an elaborate scoring system. And I won't dive into it very deeply, but it's important to know that class 4 and class 5 variants are considered diagnoses, or at least pathogenic variants, a likely pathogenic variant, but it's scoring per variant. And I'll get back to why that's important. One of the things that are important to find out is whether your lab returns all variants of unknown significance, the FUSs, or only the suspect FUSs, because that would that makes analyzing the results different. So when there's a positive result, then there's an important distinction to be made between classification, which is what the lab specialist does, what's in the lab report, versus interpretation. So the classification is the ACMG classification that I just told you about. Class 3 FUSs, for instance, may be up or downgraded with proper workup. But what if you get back a class 5? Is this always a diagnosis? Well, that's the question, but the answer is no. One, for obvious reasons. If you have a heterozygous class 5 carriership of a recessive disease, for a recessive disease you need 2 variants on both alleles, then it is a class 5, but it's not a diagnosis. And so the ACMG is about what is known about the variant. So if a variant, and so in suspect variants, a typical phenotype might push the score from 3 to 4. So therefore, it's important to describe the phenotype specifics. But even in a class 5, that might be a proven risk factor, but not 100% penetrant. It's essential to reassess the patient's phenotype critically to see whether the risk factor has actually caused disease in the patient. So interpretation in light of your individual case is key. Examples, I won't go through all of them, but examples of known class 5 variants that may not be causal for your patient. For instance, the heterozygous SLC3A1 duplication. SLC3A1 is the cystinuria gene. In heterozygous fashion, it's a known risk factor for stone disease. But if you find it in a patient with end-stage kidney disease at age 22 who does not have nephrolithiasis, it will likely just be a coincidence. Same goes for the heterozygous Alport variants that are a risk factor for end-stage kidney disease, but likely at an advanced adult age, and most people will not be in severe kidney disease. So in early onset CKD, it might have contributed, but it will highly unlikely be causal. So especially when requesting broad kidney gene panels, it's key to be critical in interpreting what the result means for your patient. Now, what is an example result? It's always a bit lengthy, and usually they talk you through it. But the gene should be mentioned, the chromosome. This is the reference data set to which the variation is mapped. It's important because if they change the reference data set, these numbers might also change and it's still the same variant. And there's the genomic position. And then in green, you see the more gene-oriented position. So this is the transcript, the RNA transcript, the coding, the base pair variation and location, and then the amino acid change and position. It will tell whether the variant is heterozygous or homozygous or hemizygous, and it should tell the ACMG class of the variant. So this is mad, this slide, and I invite you to go back to it, and I'll zoom in later. But the most important is in the red barrel, the red bar at the end is reevaluate. So you have to ask yourself a few questions. You have to create a place in the electronic record, put in the medical history, when and what you tested, and don't put an assumption as fact in the electronic health record. And always go back every once in a while to see if it still all fits. So in a positive test, you need to know how many variants there were per gene. If there was one, whether it's heterozygous, homozygous, or hemizygous. If there's 2, are they on 2 different alleles, or maybe on 2 different alleles, or for sure on 2 different alleles? You have to know the location, what kind of place in the DNA it is. You need to know the classification, but also what do we know about the gene? What do we know about the inheritance pattern? Is loss or gain of function causal? What do we know? Is it a risk factor, or is everybody diseased? And what do we know about the expected phenotype? So basically, you have to ask yourself the question, or make sure somebody else answers it. Am I sure that this is or can be a diagnosis? And if no, what to do about it? If it's negative, we need to review what was tested, what could still be tested, what genes were tested. it's important to clearly state that you ran a West-based gene panel, if not all genes of the exome, and so all coding regions of the DNA were analyzed. And it's also important to think about what kinds of variants were tested. Basically, the question is, how high is my a posteriori suspicion of monogenic disease after this result? And if you think it's still high, then you also need to think about advice for family members. You could ask ChatGPT for help, but be very careful about it. This is an example of a prompt that did give quite a good answer. Tell me in a language that's understandable, etc., etc. But be careful. The multidisciplinary meeting is more important, or is better, but it's not always right at hand. And post-test, basically, the advice is to discuss all positive results in the multidisciplinary meeting, all negative results in suspect cases, and obviously on a case-by-case scenario. And always advise to review in a couple of years. So 4 things you can do to start doing tomorrow to be aware is 1, put potential monogenic kidney disease in your differential diagnosis. Make genetic testing, yes, no, when, what, part of your standard medical history. Ask yourself whether family members are adequately monitored, even if no testing was performed. And you can start exploring your genetic infrastructure, adapt a stoplight tool, and set up a multidisciplinary meeting. And with that, I'll stop sharing, and I'll apologize for being a little bit over time, but I hope I set the scene.
That's wonderful. Thank you so very much, Albertien. And just as a reminder, as we're transitioning across slides now to Oliver, as we're going through, any questions for us to go through at the end, please just pop them in the question box, and we'll come through to them and curate them through. The CME information, again, is also in the communication panel there for everyone to click on and action as appropriate. But otherwise, Oliver, I'm really looking forward to your presentation now. Welcome and take it away.
Thank you. Thank you, Andrew, for the very kind introduction, and thank you for the KDIGO team for inviting me. So my case is about Alport syndrome, and as Andrew already told you, I'm an adult clinician, so I will tell you how I usually assess genetic tests in Alport syndrome. So, yep, here are my disclosures. Most important here is that all therapies I mention in this presentation are off-label use in children, but we are working hard to improve the evidence. So I have been the principal investigator for a randomized controlled trial with ACE inhibition in Alport syndrome, and right now I'm conducting a clinical trial with an SGLT2 inhibitor. Speaking of Alport syndrome, it's important to know what type 4 collagen is about. So we have 3 different type 4 collagen chains that are of interest here, the alpha 3, 4, and 5 chain, that obviously show up in the kidney, in the inner ear, and in the eye. And Alport syndrome in terms of genetic is a little bit complicated because the alpha 3 and 4 chains are on chromosome 2, so they are autosomal, and the alpha 5 and 6 chains are on the X chromosome. No matter what kind of variant you have in your Alport genes, it results in a weak glomerular basement membrane. So this is a normal glomerular basement membrane here on the right, and down here you see a weak and distinguished glomerular basement membrane in an Alport mice. And why do I bring this case here in terms of genetics? Because genetics really changed our life as a clinician. So this is my daily boring clinical life in my clinic. I see adult Alport patients that are diagnosed too late. However, in terms of genetics, if you diagnose the patients earlier by the secure genetic diagnosis, you not only have an earlier diagnosis, you have an earlier opportunity to treat and to make a better prognosis in terms of progression of the disease. So it's very, very helpful for therapy decision, as I will show you in the next few slides. And we already have shown in a European registry that not only you can treat Alport syndrome, you also improve quality and lifespan of your patients by earlier diagnosis and by delaying renal failure. So let me bring actually 3 cases to your mind. So the first one is typical for me, being an adult nephrologist, a young male with a long history of hematuria, but ongoing renal failure. So this male had a kidney biopsy more than 10 years ago, but unfortunately this biopsy was misinterpreted as the basement membrane disease, and while actually the nephrologist excluded Alport syndrome and did not do the genetics. Finally, we'll discuss the prognosis when the diagnosis would have been made in 2012, and we will discuss the prognosis and therapy today. And the other 2 cases I only want to briefly mention are the future, because you have an early diagnosis in early childhood. One case is from Estonia, the other one from Macedonia, telling you that Alport syndrome is really an international business. And the variants differ. So you have a missense variant, and this young boy here has a splicite variant, and we will discuss the different outcomes in response to therapy. So hopefully after this KDIGO seminar, we will improve the prognosis for all 3 patients here. So how do we do that? We first of all need a definitive genetic diagnosis. I usually ask my genetician for an NGS panel. Actually, I tell the person, well, I need a FSGS panel or a panel for a glomerular disease or for a chronic kidney disease, and describe the clinical features of the patients. And this would be a typical result. We already heard from Albertien. We have a class 5 variant in the COL4A3 gene, which means it's an autosomal variant, and we have the other allele involved with a variant of unknown significance. So how can we solve this unknown significance? Because it's very important to know if this is only a heterozygous or a homozygous, or actually a compound heterozygous Alport case in this scenario. So the first message here is that the Alport genes are huge, 150 kilobases of exome variants, and we don't have a hotspot. So there are more than 2,500 different variants described in Alport syndrome, and you must consider the genetic databases as incomplete, because usually the clinicians do not give a feedback about the clinical feature here. So you need to discuss with your genetician, and you need to be aware that you are the expert because you know the patient in person. So how do I solve this right now? This is how we solved it in our earlier clinical trial. And just to make a long story short here is that it's a back and forth between the clinician and the genetician to make a decision. So let's say the mother has one variant and the father has the other, and this causes actually in this boy autosomal compound heterozygous Alport syndrome. So let's say this class 5 variant caused the microhematuria in the mother. So I would say that's solved because it's class 5. However, in the father, I would upgrade this unknown significance because the father has a biopsy proven FSGS and a mild impaired kidney function, telling you that this is not of unknown significance. But the other way around, what about if the mother with a persistent microhematuria only has this variant of unknown significance? So typically I ask the mother to show me her pregnancy card, and this is in German, but it will tell you that throughout the whole pregnancy, the mother had a proteinuria and hematuria for 9 months. So clearly this is not unknown significance, this is significant. And let's say in the boy here, despite this unknown significance, we have this kind of hearing loss. This hearing loss actually originates from the Netherlands, but this is so classical for Alport syndrome that you can upgrade this unknown significance to we know that significance because it causes that typical kind of hearing loss for Alport syndrome. So I recommend to read the IMPRESS first guideline on behalf of ERCNET, ERA, and ASPN about the diagnosis, management, and treatment for Alport syndrome. And I just want to sum up the very simple message about therapy. So the first message here is we need a genetic diagnosis to be sure. Because if you have a heterozygous child, you would start exhibition only if the child has already microalbuminuria. But if the child has a severe Alport case, like homozygous X-chromosomal or autosomal homozygous compound heterozygous or diabetic Alport syndrome, you would start before onset of microalbuminuria because of the bad prognosis for the kidney. And finally, you would add an SGLT2 inhibitor, not in a child, because in the child we have this ongoing clinical trial to sort that out, how good SGLT2 inhibitors are in children with Alport syndrome. So it's very important to have this genetic diagnosis to make a balanced decision about therapy. So let's solve all 3 cases in my final slide. So I promised that we want to discuss the prognosis if the diagnosis would have been made in 2012. In 2012, in this boy, you would have started ACE inhibition, and this would result in additional 15 years of delaying renal failure. So this boy would have his kidney function until 2040. And right now, because of the late diagnosis, we still can delay renal failure a little bit, but only by 2 or 3 years, I would estimate. So the story is completely different, and there's 2 young boys here. We know that a severe variant and a splicite variant would be a severe variant in this case, results if untreated in early end-stage kidney failure, if untreated. But if we treat this boy with 3 years onwards with that normal kidney function and without albuminuria, we estimate, or actually we know from our registry, that we delayed by at least 15 years, if not by longer. And in this classical case with a missense variant, we know that untreated, this typically leads to end-stage kidney failure in the young adulthood. But in my personal letters to the physicians and to the parents, I write, our goal here is to treat that young male so early and to delay renal failure for lifetime because we treated that early. And we already have data published that actually in this kind of missense variant, we are able to delay kidney failure by lifetime. So my conclusion here is that I estimated that we have about 100 highly motivated physicians watching this session. Each of you will counsel 1 family per year with Alport syndrome at early stages of disease. And you and your knowledge right now will lead to early therapy because of an exact genetic diagnosis, and you will delay renal failure in this family by at least 20 years. So this webinar, with 100 people looking this webinar, we already saved 2,000 years of end-stage renal failure today. Thank you very much.
Wonderful. Thank you so very much, Oliver. It's incredibly thought-provoking. I think, and as we're transitioning across those slides now to Matt, again, just as people are beginning to cogitate through this end component of the presentations, pop those questions into the slide box, into the question box, sorry, and we'll be able to go through those towards the end. I know I'm already thinking of some to hopefully challenge our speakers a little bit, but otherwise, I'll hand over now to Matt to take it away. Thanks so much, Matt.
Thank you, Andrew, and thank you to the organizers for the opportunity to present today. These are my disclosures. So polycystic kidney disease, when diagnosed by an expert who's very familiar with the phenotype and determines that it's a classical presentation with a positive family history, up to 90% of them will be due to pathogenic variants in PKD1 or PKD2. But in clinical ascertainment of people with multiple cysts in their kidneys, up to a third of them do not have a positive family history. And a similar proportion do not have features that are classical for ADPKD. So, bilateral cyst involvement with kidney enlargement and decline in eGFR. Genetic testing in people with atypical or with no known PKD pathogenic variant have led to the discovery of numerous additional genes that can be carry pathogenic variants leading to cysts in the kidney. Some of these genes are involved in the maturation and trafficking of the polycystin-1, polycystin-2 complex out to the cilia. But many of the genes also work through different mechanisms and pathways. Indeed, some are even phenocopies that aren't related at all to polycystic kidney disease, the classical ADPKD, and are only recognized once the genetic variant is identified and reverse phenotyping leads to the recognition of the true genetic diagnosis. So I would like to start with the case of a 37-year-old who came to the emergency room with headaches and was found to be in a hypertensive emergency. He had a past medical history of attention deficit hyperactivity disorder, anxiety, and autism spectrum disorder. He reported occasional flank pain and abdominal distension. His blood pressure was elevated and he had a visibly distended abdomen with palpable organomegaly, but his exam was otherwise rather unremarkable. He was found in the emergency room with an elevated creatinine at that age of 37 with normal liver enzymes and glucose. Family history indicated no history of kidney disease, kidney failure, or diabetes. However, he was estranged from his father, so his paternal history was unknown. His mother had normal kidney function and no known kidney cysts. The CT that was performed due to the history of flank pain and abdominal distension showed this, massively enlarged cysts involving both kidneys. Additionally, there was some dilation of the ureter and the right kidney, as well as the presence of some splenomegaly, which certainly is atypical for a classical presentation of ADPKD. However, it's quite likely there are some practicing physicians and even radiologists who would say there's cysts in both kidneys that are enlarged. This is in keeping with polycystic kidney disease. Due to the lack of family history and some of those atypical features, we proceeded to do genetic testing in this case. In Ontario, in Canada, where I'm from, the first step at that time was actually capillary sequencing of a long-range PCR of PKD1 and PKD2, which did not identify any pathogenic variant. Hypothetically, what would we think, and what would you think if the results came back like this, though, with a glutamate to proline change, a missense change in PKD1 that was reported as a variant of uncertain significance? We've already heard some of the challenges in trying to interpret these variants of uncertain significance, and it can be tempting to really ascribe the phenotype to a variant, especially when it's consistent. The concern is that variants rare variants are cumulatively common. So it's really essential that we continue to follow and reevaluate these interpretations in a cyclical process that's been discussed, right? So both with the geneticist involved and the clinician involved in the case to ensure that the genetic change is truly in keeping with the diagnosis that's provided. In this situation, since the genetic testing was negative, we proceeded to an exome-based gene panel that included 43 genes, which identified a heterozygous whole gene deletion of HNF1 beta, as well as 2 adjacent genes. This was classified as a pathogenic change, given it was a whole gene deletion. Hepatic nuclear factor 1 beta, or HNF1 beta, is a transcription factor that binds to and impacts the expression of multiple genes that are involved in cystogenic pathways, including polycystin 2, uromodulin, and PKHD1. And pathogenic variants in HNF1 beta cause a multi-system disease that includes autosomal dominant tubulointerstitial kidney disease, which is the more frequent presentation of HNF1 beta. It can be associated with congenital abnormalities of the kidney and urinary tract, or CACUT, or kidney cysts have been reported, though the very large cysts in this case were unexpected. Hypomagnesemia, hyperuricemia, and gout may be present, as well as mature onset diabetes of youth, or so-called MODY, which is an insulin-deficient diabetes that's associated with pancreatic hypoplasia, as well as exocrine dysfunction of the pancreas. Additionally, there's a report of an association of neurodevelopmental disorders, particularly with whole gene deletions of HNF1 beta, which may present with mild cognitive impairment, seizures, autism, schizophrenia, and structural abnormalities of the brain. There may be a liver enzyme elevation, though liver cysts are not frequently reported. So you can see there's a long list, and because HNF1 beta is ubiquitously expressed, it's a multi-system disease that affects organs throughout the whole body. However, variable penetrance and incomplete penetrance and variable expressivity, which are the expectation in this day and age in evaluating monogenic diseases, is the rule in HNF1 beta. And so even in a physician experienced and has seen multiple cases may be tricked and miss the diagnosis without the assistance of genetic testing. So some of the take-home points from my section: well, autosomal dominant conditions don't skip generations, and so people may not think that it's an autosomal situation in the context of no family history. A third of cases with polycystic kidneys do not have a clear family history. At times, this is due to estrangement or, distance from older generations. It may be due to incomplete medical history in prior generations, or it may be due to de novo or new variants that are developed in the index case. It's important to have a broad differential and reevaluate in the context of negative genetic testing. Genetic testing is valuable, and the absence of evidence is not evidence of absence. We can see the results we get, but if we don't get a result, we can't say that there isn't a positive result. Searching in the wrong genes, especially in targeted testing, which is becoming less common as we're becoming broader and broader, but certainly even being conscious of the genes that are involved in gene panel testing is important. Wrong interpretation, so especially in sequencing in individuals of non-European ancestries, rare variants are more common in individuals of other non-European ancestries, and because there's been less sequencing in those populations, it may be more difficult to interpret variants. So circular reevaluation of variants of uncertain significance is essential in an iterative process involving both the geneticist as well as the clinician. Finally, Consider HNF1 beta in cases of congenital abnormalities of the kidney and urinary tract and autosomal dominant tubular interstitial kidney disease, but also in individuals with kidney cysts or multiple kidney cysts, recognizing the variable phenotype, incomplete penetrance, and variable expressivity. So the changing phenotypes that can occur in people with HNF1 beta. So I think Andrew is going to come back for a question and answer period.
Absolutely. Thank you so very much, Matt. And thank you to all three of the speakers today. I think that's just been an amazing walkthrough using some fantastic examples and real world examples to illustrate approaches to variant interpretation. Thank you so much to those who've been popping questions in the chat. Please keep doing so over the next few minutes. But first, to open up the discussion, I wanted to just pose the question, a few instances here of multiple variants being being identified in genetic testing, and particularly when they might be in, say, for instance, the same gene. Albertine, what's your initial approach there, and are there any particular considerations you think that are important when they're being looked at and interpreted?
Yes, Andrew, thank you. I think there are basically, but please add anything that you might think relevant. But basically, I think the rule of thumb should be that if you do a regular genetic test, for instance, a VES-based, a whole exome-based gene panel, and you find two variants in the same gene, you have to assume they might be on the same allele and simply represent a carriership and not a diagnosis for in a recessive gene. At least you have to assume that's a possibility, because most of the times you cannot be sure. What are the instances that you can be sure? Well, basically, you have to read the report, because usually the genetician will have thought about it, but might be hidden in a bit of genetic lingo, whether the variant is for sure in cis, which means it's on the same allele, or for sure in trans, which means there's on the different alleles. But usually you cannot be sure, and this is because of the way the experiment works. And only if variants are very close by, you can actually distinguish if they're on the same allele or not. What can you do? Well, many things, but the most standard thing to do is to test the parents. And this is also what the speaker showed. If you test the parents, you can see, especially Oliver showed, which variant comes from whom. And if they're from two different parents, then by definition, they're on two different alleles. If the parents are not available, there are newer genetic tests where you might be able to answer this, but please stick to the basic assumption that two variants in the same gene, you have to do work to know if they are in two different alleles.
Absolutely. Matt?
I just want to add to that, in the adult nephrogenetics world, that it's also important to consider at least siblings or
Sure.
even any other family members, especially if they have any phenotype. So familial co-segregation analysis, which is mumbo jumbo for just cascade screening other family members, can also, it may not always be informative if they also have both variants, but it can disambiguate whether they're on the same allele or not, even if parents aren't available.
Yeah, and sometimes we can do the genetic test in paraffin-embedded material from deceased parents. So this is also a trick that we sometimes use to try to figure this out.
I think it is absolutely, yeah, as you mentioned, I think this is an absolutely key point. And these are those things kind of behind the piece of paper that often confronts us at the end of a testing route. And so tricks for emerging players, as we would say, I think in my part of the world. But thank you to those who've popped the questions in the chat box. Oliver, I think there's a couple of really interesting ones here in the glomerular collagenopathy space, but and to ease us in here, a really interesting one around approaches to heterozygous variants in collagen genes for your COL4A3 and COL4A4 in younger people with microhematuria without family history. What's your approach in that situation? Even given, the absence of, say, histopathology, so a kidney biopsy to clarify things histologically, how close is that relationship, and what do you call that condition?
Well, thank you, Andrew. And I already read this question, and still it's hard to answer. So first of all, we know the frequency for heterozygous Alport variants is 1 in 100. So 1% of the total population carries this type of variants as a risk gene, and we know it's actually a spectrum of benign hematuria for lifetime. But 1%, 2% of this population still gets to end stage kidney failure, mostly because of other risk factors. To give you an example of my clinic, I have identical twins, both heterozygous autosomal, one end stage kidney failure with 55, the other isolated hematuria. Where is the difference? They originate from a small village in the eastern part of Germany during the Cold War. And one was adopted out of a disastrous family. This is the one with benign hematuria. And the other one smoked and got obese. And this is the one who actually is in end-stage renal failure. And I know this case because of the daughter, who is 22, has a normal kidney function, but a nephrotic syndrome because of FSGS, because it's Alport syndrome. And her body mass index is 41. So my major job is to start her on, ACE inhibition and on SGLT2 inhibition, but also to get her out of that family to make sure that she has the chance to live a healthier life and to eat less, actually increase her chances not to get onto dialysis. So it's a huge spectrum. And I usually would say this family, it's not a benign condition, it's a risk factor. Make sure that you live a healthy life and get to your family doctor every 2 or 3 years to make sure that you do not develop microalbuminuria. If they develop microalbuminuria, we can hold the disease by adding ACE inhibition.
And so you see it as a key thing to not minimize the interpretation of risk, but that there might be other environmental or other factors that collide with the genotype to
and please don't call it benign. It's not a benign, it's a risk factor. And make sure that they get a little bit frightened in the beginning to make sure that they keep on going to the family doctor to decrease the other risk factors, for sure. So let me ask Albertine, because it's easier to ask questions than to answer questions. We know in Alport syndrome, because of these huge genes and large regulatory elements in the introns, that about 50% of the Alport variants cannot be found by normal ways, let's say by normal genetics. But still, if I have a patient with a biopsy-proven Alport syndrome, can I call that patient solved in terms of genetics, or how would I access that kind of situation?
Probably you'll get a handful of different answers. Asking this to a handful of different nephrogenetic people that think they know something about nephrogenetics. But I would be always very careful to call something a genetic confirmed diagnosis if you did not find the genetic causative variant. Of course, there's many ways in which the hint in which you can make a clinical diagnosis of Alport syndrome, but then always call it a clinical diagnosis of Alport syndrome. And with the paper from Paris showing the intronic variants in COL4A5, we're only waiting for the studies in COL4A3 and COL4A4 for the where we see intronic variants. Likely they are there, right, and will solve another subset of cases. And the differential diagnosis of a clear clinical Alport syndrome is genetically it's not that wide, but still saying it's solved and clear, I would be very hesitant. Andrew, I would be interested in your take on that. But
I think it leads into a great question that's been put into it's been posed actually around looking into the future. At the moment, most of I think the approaches we're talking about are largely exome based, but we're moving into a time where whole genome and long read sequencing can be considered. Where do you think they sit at the moment? Is there equipoise diagnostically for these unsolved cases, or where there's exactly as Oliver said, there's a very well anchored clinical diagnosis, which doesn't change regardless of the genetic result, clearly. Where do those technologies sit? Is there, are they best as first line, as second line, or wait to see how they evolve?
Well, it really depends on your situation. In my situation in the Netherlands, our lab is currently the diagnostic lab is transitioning to whole genomes, and we'll have the nephro gene panels from whole genomes. I mean, it's not even because of me or my friend, it's just because the lab is transitioning. So we'll have them, but obviously interpreting variation outside the exome, that's I mean, sequencing it's not the challenge, it's interpreting it. But generating the data and having larger data sets available, not even for diagnostics, because in diagnostics we'll still report on the same things that we were reporting on before. But now in suspect cases with, for instance, a trio, so parents and a child, you can start diving into the introns and see if there's variants that would solve, that would maybe the missing variant on the other allele. So it really depends on your local infrastructure on how available this would be, but especially in patients that might consider reproductive options that are actually available. You have to clearly go the extra mile, and for others, maybe wait a bit.
Yep. Matt?
I just wanted to add that, the selection on non-coding regions is so much less. And so even though I say rare variants are cumulatively common, even within exomes, so in the coding sequences of the genes that we're looking at a priori, the amount of rare variation within non-coding variants is exponentially more. And so the likelihood of finding rare variants in non-coding sequence and then trying to interpret whether that's actually leading to the phenotype, it's really a whole new world. And I personally think it's still a long way from, I mean, it's certainly the future, and the cost of sequencing is dropping so exponentially that we're going to get access to that information before we know what to do with it. But
and maybe it's good to add that basically, for most intronic variation that you think might be causal, you really need additional proof. So you need the RNA to go along, or to also be affected, or because otherwise it won't hold, or at least not for now.
And Matt, actually, there's a really specific question's been asked around colliding phenotypes, where for glomerular kind of presentations particularly. So, the example given is a family where there's both Alport syndrome within a family with a VUS in a collagen 4 gene, as well as a complement dysregulopathy, atypical HUS with a pathogenic CFH variant. Interpreting those two things within a family, any takes that you have in terms of, for a person who presents with kidney disease, how would you try and disentangle that?
So I think, as Oliver mentioned, we need to keep in mind the variable expressivity, meaning that these can be risk factors, but not deterministically causing disease. And certainly if they're in combination, they can contribute together and add to overall risk. That said, I think phenotyping, so like while the genotyping may raise a flag that a possible diagnosis is there, the genotype is static throughout life. What does not, or what does change is the phenotype. And so does that person have any, thrombotic microangiopathy consistent with a component of atypical hemolytic uremic syndrome? I think, is there, of course, they said biopsy is not going to be useful because that patient has already progressed to kidney failure. Well, in the cascade screening of other family members, what are their phenotypes like? So I think it's also, as much as Albertien said that we need to be thinking of not, there isn't a reason to not do it. I really think it's really important to emphasize cascade screening because it is such a valuable way for case finding, especially early when we can intervene on these people. It's really hard to screen everybody with early stages of CKD, but really that cascade screening is vital for case detection.
And maybe also to add, because you said that the genotype is static, the phenotype is not, but also the family history is not. So every once in a while, dive back into the family history and ask again. Even today, I was, confronted is a big word, but the pediatric nephrologist called me about a quite recent IFT-140 diagnosis, which is an atypical ADPKD diagnosis, where she called me and she said, were you actually aware that the sister also has cystic dysplastic kidneys? And I wasn't, because I had only just briefly spoken to the parents. But these things change. There's new children being born, especially with kidneys. You're right. If you're not monitored, you might at some point present with kidney failure, whilst 5 years before nobody knew. So you need to go back every once in a while to the genotype, but also to the family.
I think these are really important points, which we've been grappling with in these last few years, and I've just deliberately in the background popped up the CME credit slide for attendees to begin clicking on, and I'll quickly read through this in just a moment. But I wanted to pose to the three of yourselves, a question's been asked as well about, for somebody with a secure clinical diagnosis of a disorder, and we do a genetic disorder. And we do a genetic test and we don't find any variant. Any thoughts from yourselves and key take homes as to what might be potential reasons behind that?
Well, what I usually tell patients is then it becomes interesting. But that's obviously the academic in me that says that. But it can be many things. First of all, really go back to the person who wrote the lab report and go back and say, well, from this huge list of genes that you tested, I really think it might be this and that disease. Could you please go back to the data? And maybe it was there, but it wasn't filtered out. There's all kinds of bioinformatics steps that every once in a while miss a variant, even while it was sequenced. You also need to ask what the quality of the sequencing for that specific gene was. We already discussed potential intronic variation or things in promoters or enhancers. And the alternative hypothesis is that it is another gene. So that's also something hand in hand with the geneticians you might explore. But I think I because it can become quite complicated and quite technological, this is why, admittedly, the personal statement was start with offering a broad gene panel in a patient that was not tested before, and try to build some experience with that, and take it from there. Yeah.
Thank you. But now we're reaching time, so I'll just quickly read through this slide for CME credit for our attendees. So in order to receive credit for this activity, participants need to have attended the live webinar and complete the program evaluation. So we do have some evaluation to be done as provided by our speakers, which is amazing. So the fun doesn't stop here. The program evaluation QR code is just here on this slide, and the link can be found also in the chat box as well. CME and clinical education certificates will be emailed child within 2 to 3 weeks of completion of that evaluation. And with that, I absolutely like to thank our three eminent speakers today, Albertien, Oliver, and Matt, for walking us through some, I think, real-world cases, real-world experience from some of the most eminent experts in this area as it's unfolding in front of us, because this is continuing to change. So thank you to each of the three of you today, and also to all of our attendees for coming along. Please also offline questions, comments, outbursts, don't hesitate to send them through the KDIGO team, and we'll be able to direct them to our speakers offline too. But other than that, again, thank you again, everybody, for coming along. We're so pleased to be able to provide this program at this particular point in time. Hope you have a wonderful, safe day, and we will talk very soon. Thanks again.